Thank you very much for the invitation to Pronavi. Could you hear me? Yeah.
Yes.
Okay. Thank you very much for the invitation of my colleagues. It's a pleasure for me to be here, share our experience with the Pronavi catheter. This case is very interesting because in our population there is a lot of calcium in the coronary lesions, and this case navigating between rocks and stones with the Pronavi Microcatheter. This is the case. An 85-year-old female patient was referred for unstable angina with elevated markers and Zika, with coronary angiography showed trivascular disease with involvement mainly in the anterior descending artery and the right coronary artery. In the first step, LAD was treated with a provisional stenting with this zone aneurysmatic between the bifurcation in the LAD and second diagonal branch with this result. In this patient, we decide only provisional stenting in order to mainly mainly vessel, because there is a lot of lesions, diffusing disease in distal vessels. In the second step, he was scheduled for second stent PCI with orbital atherectomy in the right coronary artery. We tried to cross tapered polymeric guide wide support with Pronavi catheter, and this Pronavi catheter was able to cross all of this proximal segment, but in the middle segment of the right coronary artery, in this segment point, the Pronavi catheter did not cross. Then we tried to cross and 1.5 balloon to try to open a little more space to cross the Pronavi catheter, but the balloon did not cross. Then we tried to advance it. It was possible to cross to great difficulty to distal coronary artery, right coronary artery. Then the microcatheter was advanced until we tried to impact the tip of the microcatheter, you see in this red arrow, impact in the area of the more calcium and stenosis, and from this, with slightly rotation of the microcatheter, this is the arrow, the guide wire of the orbital atherectomy, the Viper wire, was able to cross distal and was advanced to distal right coronary artery. Orbital atherectomy was performed without complications, and the subsequent OCT, we try to perform OCT in all our orbital atherectomies, revealed a large amount of calcium in the middle of right coronary artery with decrease of plate volume. This is the result of the orbital atherectomy. As you see, this part of this right coronary artery was a lot of calcification, very angulated, and then the conclusion of this was finally 2 stents were implanted with a good angiographic result, with this result in the right coronary artery and exit of the PCI. With this conclusion, this middle zone of the right coronary artery with the high calcium load and the severity of stenosis behave like a chronic total occlusion. It's not really a chronic total occlusion with the microcanals that the Pronavi microcatheter managed to cross the site were inserted. And this impact of this in this point allowed the handling and adequate crossing of the guide wire to distal bed to allow orbital atherectomy.
Thank you, Dr. Raymundo. Thank you for your presentation. So in this RCA case, you used the Pronavi 1.9 French, right?
Yeah.
Oh, the tapered one.
Yeah.
And what is the catheter length you used?
Sorry?
The catheter length you used. Do you remember? The working length of the microcatheter?
Length of the microcatheter. Ella is asked.
Length.
Yeah.
1.35.
Oh,
Sure, yeah.
smaller one, 2035. Okay, thank you. Do you thank you for. Do you have any question for discussions, Dr. Jose, Dr. Junior, and Dr. Trishofeltis?
Well,
Yeah.
no, well, I
Welcome
think
to
it's
join the discussion part.
Thank you. I think it's a very interesting case, and it's very well illustrated with the OCT. I think the image of the OCT is great. After the orbital device, and I think that it's an example of how you can still use this type of microcatheters. And I'm going to talk about the non-rotational microcatheters as the Pronavi. And it's a good example of how in many cases you can use the Pronavi successfully. So I think, congratulations, I think it's a very good case, very well illustrated.
Thank you much. It's a lot of cases.
Can I say something?
Unable to cross the microcatheters. It's only to impact in the point of the more tight stenosis, and then we are able to cross the lesion with the guide wire.
Just one thing, very nice presentation, congratulations. It gives a point about the calcium and the microcatheters. You know, in the past, I had some problems with exchanging with the rotawire, because even when a microcatheter can drive, you can drive it through very calcium and tortuous, calcified and tortuous lesions, maybe you cannot exchange with rotawire. I've seen that in a few cases with other microcatheters that could drive it easily, more easily than you would wait distally, but then you could not exchange with rotawire. In this case, you didn't use rotawire, and maybe we have to see it in a case with rotawire to see how you can exchange it through very calcified and tortuous vessels.
Yeah, this is not a rotawire, it's orbital atherectomy, and the guide wire is most handling. It's a lot of handling compared.
Yeah.
And Dr. Raymundo, we got one question from the chat board. Dr. Raymundo, thank you. How did you choose the tip shape of your microcatheter? In which situation you prefer non-tapered tip instead of the tapered tip? Can you?
In these cases, first of all,
in this case you use
the
tapered one.
Traditionally, we use tapered tip catheters. In this case, with a lot of calcium, there is some cases in this smooth and the tip of these catheters can broken and could still in this calcium and broken the catheter, the tip of the catheter. I prefer this Romus catheter in order to impact in this case, because if the microcatheter doesn't cross, only we put in this point and handling the guide wire, because the tapered tip, if cross slightly into the calcium, could broken the point and still in this point, and we lost the tip of the microcatheter.